of which hardly 10% are the organized one, and the remaining 91, or I can say the service provider in terms of 80% of the service providers are unorganized. And this is the big number of players who are always running and crying about the operational efficiency. My role is for more of plan and design, so I'll just talk about more about the design in terms of the sustainability. I'll come back to the point wherein we do remember when I started my career, the per bed cost goes somewhere around 45 to 50 lakh rupees, and now everybody is talking about a sustainable or a affordable healthcare infrastructure. Automatically, if the capital cost is less, my service cost to the patient is less. I do remember recently there is a group called as Global Group who started with a fundamental 100 bed with 8 crore rupees. It means 8 lakh rupees per bed is the cost of the infrastructure. Fine, you had built a good affordable infrastructure, but if I had built that castle and the operating cost of that castle is too high, as sir rightly said, 28 rupees, I would love to put a point. When it comes to healthcare, the electricity cost, there are 3 slabs. One is for agriculture, second is for SME, and third one is for mall and entertainment. Unfortunately, for healthcare, we comes on the third level, which is the highest one. So, if my cost of operating that facility is high, automatically I am gonna die from the day one. It is like as good as taking a sample from a small person. Every day you come and take a small sample, you just prick and go again and again, or you come and cut once and do it. For me, operation sustainability in terms of going green is the easiest way to start with. When it comes to the capital cost of the infrastructure, it will cost hardly 3% of the whole infrastructure. We have the part for the design in Kohinoor Hospital, which was the first lead architectural building in the country, or I can say in the Asia, and we was zapped out to understand why it worked out. Majority of the time, it is a public facility which has to be utilized by the patients and the patient relatives. That controlling these people is the difficult task. So we try to understand how and when we can control and where the efficiency comes in. Starting from the lobby, majority of the time what happened is there are 3 places where the electricity or the light has to be turned on 24/7. Those are your corridors, lobby, and the ICUs. I do remember when I just entered into a big hospital, and in the lobby itself that shut down the lights. When I asked the reception guy, hey, why you turned off? You know, the legacy of the building, or the moment you enter, it looks like it's a big castle. Then I asked him why it is so. Sir, we are on the operational efficiency project now. I said, okay, fine, fair enough. So, wouldn't you plan this thing while planning? He said, no, sir. Then we realized, okay, there are a couple of things which might be a capital cost to the infrastructure, like on the same thing, if we put up a LED which may charge 1300 rupees per square feet, per unit, but the electricity cost will be the 4 watts, which is as equals to a light which is almost around running the same light for a month. So for me, the operational efficiency is 33% can be reduced easily by the using good resources. Intelligent building or the green building, what we called as, it's not only the electricity, it can be water also, which is a precious resource, even the air circulations. Though we have lots of people from the government side, I can say architecturally these are the best hospitals which are meant, because there are very few where we had seen their centralized AC, but whenever you go inside a government hospital, the ventilations are pretty good, because the height measurements are 14 feet clear height. So those are the things which we have to imbibe. And to be frank, green is nothing. Since our ancient time, we are doing green buildings. To be frank, the oldest fort, which is built in early 16, that was Amer Fort in Jaipur, is a green building. What they have done is, it's everything, they don't have electricity, nothing, but they are built in such a way it will be run by its own. That is called as an intelligent building. So for me, the operational efficiency comes in if your infrastructure is intelligent. So you have to be intelligent enough to adopt from the day one to get an intelligent building from yourself. Thank you.
Mr. That was intelligent building, and I have an intelligent system. I run ThyroCare, the laboratory which is 160 kilometers from here. Single laboratory for the billion population. I dare to do something which no one thought it is possible. Efficiency gives rise to profitability and customer satisfaction. Efficiency is not necessarily only in terms of energy efficiency, it is efficiency of delivery, HR, training, putting things in place, lean management, avoiding unnecessary wastage of a minute, reagent and a machine standing still. We have a laboratory which is cheapest on this earth. When I say so, Indian healthcare is cheapest in the world, and in India we are the cheapest. So that gets me a uniqueness, and we receive in the night 30,000 specimen, 150,000 tests, starts at 12 o'clock in the midnight and early morning 7 o'clock all the testing is done. We work only for a quarter of a day. I wanted to emphasize on efficiency. We realize a 200 rupees revenue per specimen, 42 rupees revenue per test. Our employees do 1,000 tests a night, and our employees make a revenue of 30 lakh per annum. Why I told this is, I think in business you need to care for efficiency, otherwise both prosperity is gone and the customer satisfaction also is gone. We get specimen from all over the country every night, same night before midnight. That means not only in the floor there is an efficiency, there is a logistical efficiency. Operational efficiency is the one which is missing in an unorganized sector. In an organized sector it is there. The difference between organized and unorganized is the organized has an ability to deliver what the unorganized cannot deliver. Be it an individual, be it a department, be it a company, be it an industry, if one remains unorganized, the efficiencies are down. I have built a brand around a gland, that's thyroid. It's only 15 gram. I tell entrepreneurs, look, in 15 gram a 2,000 crore brand is possible. What about this entire 100 kilogram of body? Just pick up 15 grams each, so that you will become a very strong business brand. The challenges largely in our kind of business, I don't run a hospital, so my talk is more limited to a laboratory. The challenge is logistics. The challenge is volumes. If there is no volumes, there is no quality. And if there is no quality, volumes will never come. If you don't charge low, volumes will not come. And if you don't have volume, you can't charge low. If you don't have a reach, volumes will not come. So reach is also another big one. I am present in 800 cities in the country. All district headquarters, almost like Indian Parliament, I am present in every MP constituency. A good system and a good quality. And I want to tell you, we spend around 2.8 crores in a quality, only in controls and QC programs. But this 2.8 crore becomes only 1% in the total turnover. That makes it possible. Once again, the volume is very important. I think Madam was telling about the lack of documentation. We will keep on talking, nothing will happen until there is an agency which starts owning the patient and its welfare. I lose my passbook somewhere and I lose my passport somewhere. Forget about doctor's prescription list. I don't think we are well trained to keep things in place right from childhood. So every hospital, whenever we go next time to the same hospital, we will tell them, file gayab ho gaya. So we need to have a third party agency who is a link between we. Healthcare is not when the disease comes. Healthcare is from DOB to DOD. We must have an account somewhere where everything is now scanned and put, and some kind of identity through which it's downloaded. I want to tell for the entrepreneurs, if they are around, it's a huge business. Owning the patient, if you can own, all the doctors will be after you, all the pharmaceutical companies will be after you, even me. That's a good business. If it is done ethically, it is a good social service. We must make sure doctors or institutes or hospitals, everyone follows an Android protocol. It is all loaded into a server. A good program, if it is made, every doctor will be very happy to document. If we feel they are not documenting what is essential for the patient, it is because we don't have a system. Today people don't write. People are willing to type. People are willing to use both their fingers to type. So I think we need to change towards that. I wish a lot of efforts are put to create a good system which will in turn increase the efficiency. I think I was told 10 minutes. Another 3 minutes, if there are any question, I will attend to them. Thank you very much. Thanks for attention, and good luck.
Good morning, ladies and gentlemen. Good morning, Chairperson, my co-chair, co-panelists. Thank you very much, organizers, for having invited me. I was a little surprised to have been invited to this summit from Jaipur, Rajasthan. I was just thinking loud what was the great reason for spotting me, because I am a clinician, almost 95%. 5% I am dealing in admin because of compulsive reasons, because our own promoted hospital. But I am an intensivist. I have been involved with development, promotion, and research in critical care medicine. I have been involved in promotion of 2 hospitals in Rajasthan, Jaipur, and I had requested the organizers to give me 20 minutes if the chairperson permits me. This is the hospital where I work, and this is the ICU. I wanted to show you this ICU picture because we have 1 nurse, 1 patient ratio in our ICU, which converts into efficiency. It is 1.5-year hospital. It is focused on trauma and critical care medicine. This is another slide I wanted to show you, just multi-organ failure syndrome. First 500 cases in last 24 months. International mortality is reported at around 40%. Indian mortality is 65%. Our mortality in first 500 cases has been less than internationally reported. It will go up because we have been quite excited, enthusiastic. It's a new hospital. We do not have hospital-associated infection, but it will go on. But I'm sure it will be much below the reported Indian and accepted Indian mortality of 65. It should be somewhere around 45, 46. Most of you, I'm sure, are administrators, hospital promoters. There may be few conflicts because I'll be talking hardcore clinicians' view of efficiency in critical care medicine. And I am a full-time intensivist, a part-time administrator. I've been promoter of critical care medicine in this country for last 10 years. I've been president of Indian Society of Critical Care Medicine, and I've been the chair of the guidelines committee of Indian Society of Critical Care Medicine, which formed guidelines for planning and designing ICUs in India. And I have lots of chapters in many textbooks on chapters on ICU designing and planning, mostly from clinical point of view. So there will be maybe some few conflicting opinions and expectations from my side. Ladies and gentlemen, over the last 1 decade, healthcare is becoming transparent and customer oriented. Patients and their relatives have the right to know the standard of care and its costs. We know that now, with so much of spending and marketing. Quality of service offered has to be of high standards. Result of intervention and treatment have to be generally told to them in advance, forecasted in a way. A little bit of astrology is involved. My patient coming with multi-organ failure, and I have to tell my patients whether he is going to survive, what is the chance, 40%, 50%, 60%. And it is with great difficulty that we also have to make them aware and accommodate with us a possible undesirable outcome right in the beginning when we start treating them. This change has required the healthcare provider to be efficient and prudent in management of services and delivery of healthcare. What is operational efficiency in ICU? To my mind, operational efficiency of any healthcare unit is judged by its quality indicators. It is particularly more relevant in ICU because of the high cost and mortality involved. Therefore, we have to depend on quality indicators which are very, very important. And the basic philosophy which can maintain these indicators will depend upon how much standardizations we are able to develop. That means the standard deviation has to be constant, it has to go down rather than go up, and the pendulum should not move too much between the lows and the highs. There should be a continuous zeal for improvement of those standard procedures and processes, and there should be a gradual bettering of the parameters which have been achieved earlier. And anything which brings down those standards should be strictly opposed to and prevented. And the last but not the least is innovation. Innovation is the need of the hour, and who will do the innovation? The man on the field, the leader in the field. The leadership has to take the responsibility of innovating, finding new ideas. Our Prime Minister has said, give me ideas. You know, unless the leader gets ideas from the field, we cannot innovate. And if we cannot innovate, our standard deviation will move too much, because it cannot stay stationary at one place. Either it has to improve or it has to deteriorate. So if we do not innovate, if we do not improve, then it must deteriorate. That must be prevented. Standardization has to be achieved by the unit or the team ICU which works in the field in the ICU. They have to maintain the standards. They have to achieve the standard deviation within the control. Innovation mainly has to be motivated by the leadership. Leadership of the organization, leadership of the unit, leadership of the nursing team, leadership of the other paramedical, including the class, what we call as the housekeeping force, even the cleaning team, or even the clerical team who are working on the computers. They let us know, sir, why don't we put these data in this particular manner? It will be very, very difficult to retrieve this data, and this becomes very, very rewarding. So we must encourage innovation and improvement all the time at all levels. As a clinician, I have always felt that what is operational efficiency in ICU? Whatever occupancy, whatever revenue your ICU may be generating for the administrators and for the balance sheet purposes, it will largely depend upon the outcome, whether the patient is surviving, coming out of the ICU healthy, the ICU stay of the patient, what we call as length of stay in the ICU, satisfaction of the doctors and the staff is very, very important. If they do not they are not satisfied, they will not stay there. There will be high traffic. Burnout of the doctors and staff has been a problem in ICU all over the world, and this is particularly getting worse in India because of rapid development of healthcare delivery and development of corporate sector hospitals, and ICU are very, very high on their priority list, and they take away doctors, the duty doctors, the nurses from everywhere, anywhere. So if you want to retain your best doctors and nurses, their satisfaction and preventing their burnout is very, very important. Patient relative satisfaction, most of us agree, there is no controversy about that. I will not dwell on that. Key performance indicators is the term used mostly by administrators, and so therefore I have to discuss this particular subject. This has not been developed in India, unfortunately. This has been developed in Western countries. They have practiced it. We are trying to adopt it, but unfortunately we have very seriously failed in adopting and tuning our system to these KPIs. We depend on these indicators at least only for theoretical consideration. We have not been able to transfer them into our practice. Hardly any institution has implemented them in letter and spirit. There may be one odd exception somewhere, somehow, but I am not very sure. Monitoring the outcome through quality indicators has not been institutionalized. Major reason appears to be the fact that majority of ICUs in India are being run as open or semi-open, semi-closed ICUs with unaccountable custodians. It doesn't belong to anybody. The accounts department is interested in revenue. The administrators are interested in occupancy. The doctor is interested in 8 hours duty. The clinician is interested in his patient surviving. Whatever he has to do, whether it is ethical or non-ethical, 3 antibiotics, 5 antibiotics, 6 antibiotics, doesn't matter. So we have not been able to, and this open or semi-open ICU system has been the Waterloo of our critical care medicine system. These parameters should be put in place and audited at predetermined intervals if we want to practice them and adopt them. This will give us a strong and valid information about efficiency of our system. The need is on the ascend. It should be mandatory for an institution to have these indicators, then compare their performance level with national standard and international standards, use this data to improve this quality through standardization processes. Now, what are the key indicator parameters? I have chosen only few which are practicable, which we can put into practice in routine. Mortality, the SMR which we call, morbidity, mainly the most important one is iatrogenic pneumothorax, which we induce while putting in central lines, while with ventilating patients. This is a very, very common complication that develop in ICUs, which can be prevented by prudent methodology and protocols. Decubitus ulcers, just turning the patient left and right, right or left at regular intervals is a small effort on the part of the nurse or the doctor or the attendant who is attending, and incidence of acute kidney injury by prudent actions, or not using nephrotoxic drugs in patients who are predisposed to. These are, very common problems, and we just cannot help these patients. The prognosis of a patient who had come with about 70% survival chances, if he develops acute kidney injury after hospitalization in ICU, his prognosis suddenly halves in a matter of 24 hours after hospitalization, just because we have done a contrast media examination without having fully rehydrated the patient. We have used aminoglycosides in heavy doses. We have given a few doses of vancomycin to these patients without realizing this patient has been exposed to a possibility of acute kidney injury. Operational parameters like length of stay, readmission rate into ICU. The patient is transferred from the ICU to the floors prematurely by the clinicians who are not well versed with the prognosis of these patients, and when these patients should be transferred into the ICU or out of the ICU, because it's an open ICU, because the patient belongs to them, It doesn't belong to the ICU team. The administrator is dependent on the volume that is faced by these clinicians into the hospitals and into the ICUs. So they are the masters, and they move the patient in, they move the patient out of the ICU. They do not respect the views of the ICU team, and the result is premature transfer, and the patient has to be re-brought to the ICU, and the prognosis of these patients go down by almost 75%. Incidence of errors by either by omission or commission. This has to be a regular exercise. If you drive, you will have accident. If you swim, you will have drowning. But that doesn't mean that if we practice medicine, we will continue to commit errors. We should prepare the list of errors committed in last 3 months and brainstorm them and bring them down one by one. The target should be set every quarter of the year, and these errors have to be brought down. Errors in the ICU, these are very small things. Fall of the patient from the bed, medication error, one medicine wrongly read for another, adverse events or error rate, needle stick injury, re-intubation rate. Again, you know, because the clinician is not an intensive, he doesn't know, he wants his patient to be extubated as early as possible. He thinks that the intensive care team is unnecessarily ventilating the patient, it can be extubated, or he doesn't agree to the idea of tracheostomizing these patients, and they are extubated prematurely only to have to be re-intubated. Again, the prognosis of these patients goes down, their length of stay in the ICU is enhanced, they are subjected to infections. Nosocomial infection, we've been talking about hospital associated, and this is a huge problem. This is ubiquitous, and unless we deal with it with high hand and with a stick, if I may say so, we are going to have a very difficult times ahead of us. We do not have antibiotics in our bag. We do not have systems and methods to control this. There are very simple ways and means we can control these nosocomial infection. Approximately 1.7 million infections and almost 1 lakh deaths in the United States. Ours is unaccounted number of deaths because of nosocomial infection. Whatever we say, whatever we mention is the iceberg of the real problem. The 3 most commonly monitored variables in ICU are VAP, ventilated associated pneumonias, bloodstream infections, urinary tract infection. Because of very casual way the central lines are put, very casual way the urinary catheters are put, in very casual way the endotracheal intubation is done by the duty doctors or the anesthetist when the patient comes, because everybody is in hurry, patient is critical. Each one of these is a complete surgical procedure and should be practiced as if a complete big surgery is being done in an operation theater. Unless we imply that in our ICUs, this problem is going only to further proliferate. Human resource, if you want efficiency, should be adequate, competent, motivated and satisfied. Motivated and satisfied is very, very important. Even if you have a lesser number, if they are motivated and satisfied, they should be monitored. Low attrition rate, this may be achieved through innovation, automation, motivation, opportunity creation and burnout prevention. Opportunity creation, I have observed during my last 20 years work in ICU, keeps your younger residents and experienced nurses with you even at a cost of higher salaries. They sacrifice higher salaries, measure attractive destinations if they are motivated in terms of opportunity creations, which may be in terms of becoming a teacher, becoming a researcher, have additional empowerment that will help their retention in the organization. Other factors may be fair equipmentation of the ICU. You should decide whether you want level 1, level 2, level 3 ICUs, bed doctor ratio, bed nurse ratio, protection from emotionally charged crowds, sufficient in rural areas of the country, emotionally charged crowds, still, sometimes manhandle ICU doctors and nurses. That has to be prevented. Sufficient vacations for the staff, empowerment of the staff and doctors, regular updates, CMEs encouraged. I've noted that if you organize regular updates, CMEs, research programs, allow them to speak, allow them to present presentation, encourage them to visit during the conferences, other stations, that will help their retention and motivate them to work with you. Customer satisfaction, you are better versed with it, how to satisfy your clients and customers, so I'm not going to elaborate on that. But 2-3 slides on open care system. Is the ownership of the patient rather than professional competency of the doctor, which has allowed incompetent doctors to handle ICU patients. Even now, in large number, in almost every hospital of any repute. The institutions generally have lacked courage to annoy patients fetching and owning doctors. They have been generally welcome to treat independently in ICU, and ICU doctors and charges and directors have been asked to hold on and not to confront these doctors to treat their patients with whatever medication protocols, good or bad, right or wrong. This has highly compromised outcome and efficiency in our ICUs. Competency in critical care has been badly compromised to justify open care system. This is not an India-specific story. This is prevalent in quite few countries, including United States. This reduces efficiency of ICU as much as 50%. Some government institutions have been able to stop the open ICU cares in India. Studies have clearly shown that the closed system outcomes may be positive by as much as 40%. The prognosis, the survival of the patients have been noted to enhance and augment by as much as 40% if the patients are managed by a closed team. Just 2 minutes, sir. Critical care requires focused 24/7 attention by single team, by a single leader. Non-intensives are not well versed with recent advances in ICU protocols and techniques because they are very busy with their outdoor patients, family practice, and techniques though they may be master of their own subject. Inadequate fluid therapy, inappropriate delayed antibiotic therapy, delayed ICU transfer and premature transfer from the ICU have been the major issue which have come in way of outcomes. Infection control measures have never been their passion. Their poor availability in times of crisis has been a major issue all the time. The visiting physician has got a tendency to treat in ICU in charges as their support staff only and not treat them as their colleague. This invites conflicts and demotivation. Some of the ICU specific modalities like ventilation, CRRT, plasmapheresis has never been their forte. Therefore, empowerment of the intensivist and his team is a major issue to augment efficiency of the hospital in terms of ICU patients. This is like allowing a general surgeon to do neurosurgery, which they used to do when there were no neurosurgeons. So similarly, now you are allowing general physician or internist or respiratory doctors to do intensive care when the intensive care specialists are available. Part-time anesthetists or physician intensivists are not appropriate for full-time ICU management. Time is not too far away when patients' relatives will start asking at the very entry of the hospital, do you have closed care system? Otherwise, they will walk away from your hospitals. This is already being reported from countries like United States because the open care system is quite prevalent there even as of now. So I am concluding standard planning and designing of the ICU is recommended. There should be optimum equipmentation, regular standardization, improvement and innovations. Standard key parameters should be observed. A sustained campaign must be started to implement closed ICU care if our ICUs have to deliver good results at par with Western countries and as at par with expectation of our patients and their relatives. Thank you very much, Mr. Chairperson, and ladies and gentlemen.
No, go down. Leadership award. Go down. Final PPT actually. Respected Chairman Sir, Honorable Health Secretary, Government of Maharashtra, Public Health Department, dignitaries, organizer and friends. I am going to speak on health infrastructure in Public Health Department. As you know that the Government of Maharashtra, the Maharashtra, is a progressive state, and in its progression, healthcare delivery in the Maharashtra is one of the major determinant. The government, public health department is more concerned with the primary health care and secondary health care. The private sector is more concerned with the secondary health care and tertiary health cares, but in the rural area, the government of public health sector is the only major service service provider. You see, the Maharashtra has got almost a population of 11 crores, and in which one of our issue shown in this slide is a sex ratio. As we know that in Kerala, for 1,000 male there is more than 1,000 females, but in the Maharashtra it is one of our health issue which also needs the attention of which needs our health delivery care system to be in that direction. If you compare the impact of healthcare delivery of the Maharashtra with the government of India, you see that our birth rate is 16.7 as compared to the 21.8 of India. Our IMR is 25 as compared to the India's 44. Only two states, Kerala 12 and Tamil Nadu 21, are ahead of the Maharashtra, and this is the most sensitive indicator which shows which shows how the healthcare delivery system is in the state. As you know that the Maharashtra has got a 43,000 villages, and here we have a primary health center for 30,000 population in rural area, 20,000 in tribal area, and one community health center, rural hospital for 1 lakh population. We got women hospital, two super specialty hospitals, and many training institutes also. These are the few. I will be talking of our PPP initiatives, which are PPP initiatives, and in these initiatives, our major programs are health advice call center, palliative care project, specialist medical dental camps, epilepsy camp, health volunteers, mobile medical unit, EMS, outsourcing of clinical services like radiology, laboratory, outsourcing of non-clinical services, telemedicine, capacity building, sickle cell programs, Rajiv Gandhi Jivandayi Arogya Yojana, solar photovoltaic systems, community-based monitoring, involvement of doctors' organization like IMA, Foxy in various programs, NGO and NACP and other national programs also. I will please can you come please to just it is locked. Just दूसरा है थोड़ा सा ये कर थोड़ा सा just yes. It's not. Friend, we got a yes. We got a health infrastructure at a district level, sub-district levels, then at a village level, and our we got a specialist unit, we got a ISO recognized centers, SNCUs, dialysis unit, blood storage files. We got a multi-storage building specialty hospital to a single room in a village where the in which sub-centers the health services are provided by our ANM. This is a super specialty hospital of Nasik. You can see here the primary health center. We got a primary health centers. Operation theater is also shown of the PSCs. These are the PSCs and rural hospitals. And there are many villages where there are no roads in the tribal areas like in Nandurbar districts. The patient can take 6 to 8 hours to reach to the taluka place, particularly near the Narmada dam. And here our team, our PSC goes in the launch and to give the door-to-door services in 42 villages of Nandurbar districts. In some forest area, RCC construction is not allowed. We cannot construct the RCC sub-center and PSCs. And there, we have found out the ways that we have constructed the fabricated sub-centers and PSCs, and we are providing the services in a few forest lands. We got a dialysis unit in our district hospitals, and we are providing dialysis to the poor patient at the district levels. Our main aim is a qualitative health care regarding the primary health care. In this primary health care, the maternal health care and children health care, these are the two important, because we want to reduce the AMR and MMR. And to reduce the MMR, we got ANC care and PNC care. We are giving honorarium in the JSY scheme to the pregnant mother who are the below poverty lines and belongs to the certain communities. Then we have started Janani Sishu Suraksha Karyakram to provide the free maternal health care. We are giving the Matrutva Anudana Yojana in the tribal area so that the maximum pregnant mothers get the maximum pregnant mother comes to the institute for the delivery. We got in the JSK program, every mother is picked. They have to only call 102 number. A ambulance goes to them, takes them to the hospital, PSC, to the private recognized hospital for the institutional delivery, and she is provided free of the service. Again, she is dropped back to the her village by the ambulance. This program is inaugurated by the Honorable Chief Minister in the Parbani. These are the vehicles by which the mothers are brought. These are the mothers, they are dropped to their villages. Then we got this MCTS program. Under this MCTS program, every pregnant mother, every newborn is online registered and he is monitored. What services is due for him, what services to be given to him, everything is monitored on the line, and almost 60% of the mothers and children's data is updated in online. Then we have got many programs for the for the children care, particularly RBSK, that is Rashtriya Bal Swasthya Karyakram. And under this scheme, 0 to 18 years children, they are examined twice a year by a team of a doctor. At every taluka place, we have constituted 3 teams with 2 doctors, 1 gents and 1 ladies. They are the medical graduate plus a nurse and pharmacist, and they are not working in the institute, but their job is to go to the school, go to the Anganwadi and examine all 0 to 18 group people and treat them. Those who need the referral services, specialty services, refer them, take them, and even we have provided services like a heart surgery, correction of congenital anomalies in this age group. Then we got SNCU, NRC, then child treatment center at the village level, then VCDCs, home-based care, so that our IMR can be reduced because at present the lowest IMR in the India is of the Kerala. We are the third lowest in the country. These are the various our RBSK doctors and teams screening the school-going children. Then second our activity is the early initiation of breastfeeding, and through the Ashas we are promoting that immunization. Almost more than 90% of the children are immunized in the basic primary immunizations in the country. This was also evaluated by the third party, and it was found that more than 60% children are fully covered in our immunization program. And only because of the government public efforts and NGO involvement, we could eradicate the polio from the country. Then this is one of the new initiative of our government. In the school, we have found that many children are suffering from the convulsive disorders, and there is a need to be examined by the neurophysicians, expert doctors. And in the state, we are organizing the epilepsy camp in the state with the help of Epilepsy Foundation. Almost 10 to 12 neurophysicians from Mumbai and from the local area attends. The free EEGs are done, EEG examination is done in this camp. Counseling, speech therapy, physiotherapy is provided, and the provision is made for a free medicine to the epileptic patients. These are the These are the few patients. Here the EEG done in the camps. Two machines are there. Then we got a adolescent care. We got a 60,000 ashas. These are the local lady volunteers, and they are our community mobilizers. They bring the patients, they bring the beneficiaries to our institutes. They are paid on the performance basis. These are the ashas from Nandurbar districts. Then we got a telemedicine project. District hospitals are district and sub-district hospitals are attached to the resource mode at the medical college. Honorable Secretary is inaugurating our telemedicine program. Then EMS, this vehicle is specially designed for the Maharashtra. The AIMS Delhi was our then Ayush, we have also introduced the Ayush programs. This is the Health Advice Call Center. The Health Advice Call Center is a unique activity in the Maharashtra. Recently it has got the e-governance award by the government of Maharashtra and e-India award in the e-India summit at Hyderabad also. Here 24/7 the health advice regarding the medical care, regarding the program, disaster, epidemic outbreak is available to the healthcare provider, including the ASHA. So they are capacitated, and their response to the healthcare to provide the healthcare is very good. Here the certificate is given to us. Then we got palliative care. These are the single rooms constructed in some villages where a lady, where it's not sure that she will get the vehicle in time to come to the hospital for the delivery. So she is brought here, she is treated, she is given the free food along with her husband and one relatives and kept here till she gets the labor pain, and then she is shifted to the PSCs. Then we got many initiatives. We got a e-office. Our NRHM office is totally e-office. No papers are there. Every file moves through it. We got telemedicine. We got ASHA software, MCTS programs. Then to reach to the underserved villages, we got a mobile medical unit in the states with one doctor, and this program is run with the help of NGOs, and the villages are identified and we are providing services. These are all mobile medical units. And lastly, from this year, the NUHM, that is previously we were in NRHM, we were only giving the services to the rural area, but from this year the services will be started in the slum areas of the metros and urban areas, so the total gaps will be identified. Thank you.
Secretary ma'am, all the chairman and dignitaries, and dear my friends, good morning to all. At the outset, I would like to thank the organizers to give me the opportunity to speak. So far in this issue, Dr. Rathod, Dr. Rungta and Dr. Velumani, they had a talk about the total infrastructure, and I'm amazed that the government of Maharashtra has got a lot of schemes in the rural areas particularly. But I'll be talking as I'm basically an anesthetist. I'm in the operation theaters more than 3 decades, and I'm involved in the hospital. Our hospital designing right from the beginning, day one. So the designing perspective of the hospital building per se, I'm going to talk. I'm not going to talk about the other part of the things which other speakers they are already talked. So this is the 250-bedded multi-speciality hospital where I'm working, and I was involved from the right day one in the designing of the hospital. So just I'll show you, this is the emergency section of our hospital. where the casualties are coming, and then I'll proceed. So there are a lot of specialist architects available in today's era to design the hospitals. But when we started with our team of doctors and architecture team to design the hospital, and we gathered information what should be available in the hospital. We felt that hospital should be staff friendly and patient friendly. So we started designing the hospital, and we were involved from the day one. So in my opinion, hospital infrastructure planning in the initial stages requires high level of expertise in terms of architectural input, clinical utility validation, and mechanical, electrical, and plumbing inputs are taken before starting the designing. A close interaction between the designers, doctors, and doctors from various specialties is a must. That's what I feel. And before starting any designing work, it is equally essential to get the minute designing details ready before starting the construction. Extra care should be taken to provide dynamic design that can accommodate any future upgradation. Now, after doing this also, now our surgeons are demanding that we need operating CT, operating MRI, which now it's impossible. So this is my advice, those who are beginners to design the hospital, it should be incorporated in future plan. Technology is day by day getting advanced. So during the initial planning, consideration should be given to identify the systems for handling emergency situations. For example, designing of the fire escapes. The Amri incidents happened in Kolkata and there was a problem. So thought should be given beforehand, before designing the hospital. One has to keep in mind the escape routes, accommodating the fire detection and firefighting systems, and designated assembly areas one has to keep in mind before designing the starting the construction. Design should provide for the service corridor, ducts, and chutes as necessary for ease of maintenance without disturbing the day-to-day operations of the hospitals. I think first speaker was talking about this chutes and all, and that saves a lot of man hours if the chutes are available in the hospital. Now coming to our hospital per se, these were the expectations for all. Noble Hospital appointed a team of expert consultants from the field of architects in designing before starting the construction building, and we took the team of the architects to various hospitals in the country, and we showed them how the hospitals are functioning, and we interacted to the administrators there, what are the flaws they are getting in day-to-day operations of the hospitals. In designing, the space has to be designed considering the flow of the activities and patients' movements. Due diligence in the design is considered to safeguard any untoward damage while patient transfer or material transfer. At every stage, infrastructure should complement. In our hospital, it is complementing our clinical and patient needs as on today. So ours is an accredited hospital. As far as infrastructure designing per se, I didn't get a single NC in the pre-audit itself, except some minor these things. We kept the thought in the infrastructure. Some basic norms were followed during the planning the infrastructure, considering the infection control requirements also. Separation of curative and preventive area, which was given a thought, and accordingly the things are designed. Appropriate traffic flow, for example, dirty utility movements should not be through the clean area, which was given a thought beforehand, and the location of sinks, dispensers for hand washing, etc., were properly taken care of. Convenient location of the soiled utility areas were designed early, and then the things were in place. Isolation rooms and anterooms at appropriate places were designed. Location for adequate storage and supply areas were designed in advance. Properly engineered areas to linen service end and solid waste management were properly designed. Air handling units were properly engineered for optimal performance and easy maintenance of the repair. gas, vacuum manifolds, etc., and its control at strategic places. In the sense, gas valves are placed in every floor and every critical area where there is any problem. One can isolate that area itself, not the whole of the hospital. That care is taken. That's the detailing of the junctions of the gas isolation and right locations and zonings were considered beforehand before designing the hospitals. This is the one the actually architecture flow which we designed for the casualty. This is the stretcher lift, and our casualty entrance is from this area, and this is the casualty medical officers are sitting in this area, and this is the whole area is our casualty beds. There are around 12 beds where the zoning is done, and the in charge of the casualty is sitting here, and medical legal cell is here, and attached with the casualty there is a operation theatre which it has got all the areas which are required for the operation theatre. This is the operation theatre area where the clean utility, dirty utility, storage space and changing rooms are given. So any emergency comes, immediately patient is shifted to the theatre and primary things are done in the theatre. And along with this, the service which are required like X-ray rooms, MRI, CT and sonography is attached with the casualty, and this is the casualty complex which design, and which is as far as patient flow and management concerned, becomes easy for us to manage the casualty patients. And immediately after the casualty we have operation theatres, and patients are wheeled to the operation theatre if there is any emergency. This is just I have taken one corner of the operation theatres, wherein we have lined up 6 operation theatres like this, and this is a OT1, OT2, OT3 like this. Almost they are the mirror images. This is a one theatre complex wherein OT1 and OT2 are clubbed together, and this is the scrub area for the theatres. And these are the knee-operated scrub stations wherein and this is the preparation area for the people including surgeons and supportive staff to get prepared in the theatre. And then this is the theatre area. So I was talking about the theatre. This is the where we have a pass box which we have introduced in the theatre, and whatever dirty things which are used in the theatre, they are going through the pass box to the dirty corridor. This is the dirty corridor which is with this, and from dirty corridor it comes to the, this is the area where the cleaning, manual cleaning starts, and where after the cleaning we have here the other equipments like ultrasonic cleaning, drying, disinfecting, and then after inspection of the everything it goes to the preloading area of the autoclave, and there the autoclave are installed here, and this is the storage area from where the requirement of the storage area, this is the sterile store area, from all the requirements go through this station. This is a corridor in the theatre where here the pressure is on higher side, here the pressure is on lower side, and here lower than this. This is all the ancillary area wherein the staff is coming, changing and everything. This the whole area is utilized for the staff utility and storage. And this is the where the corridor and the sterile store material is issued from this area to the respective theatres. And this is the chute wherein all whatever things are coming through the dirty corridor which are not coming except the instruments where it comes, it goes through the chute directly to the ground floor from where it is it goes to the laundry or the garbage area. Another flow which I wanted to show you, this is from our the architecture diagram. This is the OT, ICU. We have a cubicle system. There is a first cubicle, second cubicle, third cubicle, fourth cubicle, and all are here. There is a barrier in all the cubicles, and this is all area which is a supportive area required for the staff, storage and everything, where the patients are filled in with 2 barriers, and then the critical patient goes in the first cubicle. We have medical ICU, surgical ICU, then CCU1 and surgical ICUs like that. The isolation of the, and there are some isolation rooms and couple of beds are with the dialysis machines. This is how the flow is very easy. The building and this is the same area. Now we have added 4 more beds of the isolation units after the swine flu in Pune city. So, keeping in mind this designing of the infrastructure, one has to keep in mind the maintenance of the infrastructure. Having ultra-modern infrastructure has no meaning if you didn't have 24/7 maintenance support. So we have tried to keep with the senior most chief engineer in the hospital to maintain this building. Sufficient backup and support for all important services like water, electricity and air conditioning and medical gases, and regular preventive maintenance and upgradation of the facility we are trying to maintain. Thank you.
कर दो बाद में
Good afternoon, everybody. First of all, I'd like to thank the organizers for giving me this opportunity to share a few points about this topic on operational efficiency and patient care. I'd like to say thank you to Chairman Sir, as he rightly said, the topic is vast and there may be repetition. But fortunately, in spite of the organizers not saying so and giving the particular topics to particular speaker, fortunately there hasn't been much of a duplicacy. Maybe the topic is vast, so anyone can choose anything, and secondly the organizers are fortunate enough to pick up the speakers of a different speciality. Now today, I just want to put up few points. The Indian health industry, though there are big managers here and quality control and who has put up big hospitals, this Indian health industry is going through a very crucial phase right now because it is going to grow in this century. The reason being, you take it or don't take it, it is going to grow. The reason is Indian population is growing. Today 1.2 billion to 1.4 billion in next 10 years or so. Indian economy is growing, becoming global, the education level is high, the spending power of the people is going up. Secondly, the geriatric population, because the life expectancy is going up. It is going to be from 96 million today to 168 million in next 10 years. And as all of us in healthcare industry knows, the geriatric population really requires intensive medical management, and that is going to create a lot of opportunity as well as the burden on us. Secondly, the medical tourism, though there are still some, we have some suspicion how much we are going to grow, but certainly in some of the pockets it is going to grow because the Indian doctors are skilled, they have been developed as a brand throughout the world. So with the good infrastructure, it is going to grow. So you take it or don't take it, in next 10 years this industry is going to grow. Only the question is, are we going to have it as a sustainable growth? Maybe given opportunity, as you have seen it, lots of industry with IT industry, automobile industry. Whenever there is opportunity, everybody throws into their ball into the court, but at the end of the day, not all of them will be successful. So what is a success for this industry? And for this industry, most of the people, and I'm just talking about the lay people, not necessarily who are studying, is thinking about the technology, putting up the big infrastructure, big major hospital, like recently our health minister had said, there will be few more IIM and AIMS in the country, but is it going to give us a sustainable growth? But to my mind, only successful healthcare venture can sustain, and only sustainable models can give a significant social impact. When from the government forum, people talk about, the universal health, giving some social, as the medical profession has been seen more as a social responsibility or catering to the society or equality. But for that also we have to have these sustainable models in this health industry. And for this, I feel today's topic, which has been given as operational efficiency and patient care, are the important pillars for sustainable growth of this model, not only to create a brand value for this health industry, but for our very survival of this industry depends on the operational efficiency and the patient care. As the topic is very vast, I will just a few of points which I come across during my practice. There are many ways to enhance this operational efficiency by reducing unknown, unnecessary and inefficient operational complexities. Areas include process variability, matching patient needs with required staffing levels, equipment procurement, utilization and many more. To my mind, as our quality control managers and all these managers have seen the end-to-end process. And these flowcharts, there are flowcharts in every hospitals. Of course, with these NABH and NIBH and all these quality control models, this is in place. But what is most important is, are we going to observe and are we going to supervise that these end-to-end processes are well implemented and executed. And mind you, if you create these end-to-end process models, you write it down very well like a textbook. We also call in a medical college, each and every student learn from the textbook, everything is there in the textbook. But what is executed is most important. Maybe when you get these quality control and some accreditation, we have everything in place. But the whole process, and even especially in healthcare, it is a dynamic model. Every day to day you have to see that this end-to-end process is properly maintained. Like for example, in my case, like a surgical patient, you have scheduling of patient, pre-op, operation, recovery and shifting to the wards. It has been written well down, and it is handed out to each and every person involved. But if it is not monitored on day-to-day basis, and if you don't look at that surgeon, suppose the surgeon, one surgeon is a big surgeon, calling himself a great surgeon, and he keeps coming late and nobody is talking anything to him right from the top manager, and then the whole system is going to get involved and affected. So somebody has to look into the thing every day and day out, it is well planned and implemented. It saves time, it gives a better patient monitoring, reduce the overhead, improve efficiency, prevent clogging for any reason. So the benefits are well known. But sometimes, the people start complaining, the individual performance, because of this system. There's a surgeon who is very busy. Maybe, he's busy, he's operating in 3-4 hospitals, and if he takes little time in one hospital, his work gets hampered. So that individual performance might get little hampered, but overall, the productivity of that hospital will be enhanced if we take a look at it. So the coordinated efforts are very important at every step, or else there is a collapse and overall performance of the system get affected. Now suppose, not only this individual we have to see, but at the same time, staffing of each department we have to look into. Sometimes, we concentrate, like I myself is a surgeon, so I concentrate more on the operation theatre. I will keep the best of the nurses in the operation theatre, the best of the assistant and technician. And at the same time, I don't keep the proper people, even the required people in the pre-op room or even the post-op room. This is going to get hampered. Suppose you have only one nurse thinking, what is there in the pre-op. You just have to check the registration. You just have to check some parameters and send the patient to the OT. But if this nurse takes too much time to get that patient into the OT, the whole thing is going to get bottlenecked. And at the same time, even similarly to the post-op, if thinking post-op is just a monitoring and you keep little less nurses, and if that nurse cannot handle that number of patients, then the next patient from the operation cannot be taken. So you have to look into each and every department and this process improvement. Now this, if it is every day, what we have to see this process improvement again and again. I'm saying we can write it, well written, all these SOPs, and the end-to-end process, but it has to be seen on day-to-day basis, and we have to find out and correct those defects which have been seen by 20, 30 years back by the automobile industry, and which is very apt for us today even to implement that. Next is, these SOPs or standard operating protocols, and which are very, very essential. And of course, as I said, all the quality control managers put it in place. But what I found out in some of those SOPs are, they are like a jargon, and sometimes, it becomes difficult. So we have to have a very specific SOP. I have seen SOPs, for CABG and for DIND, it is the same thing. You can imagine to have the SOP for the CABG and doing some lipoma or cyst to be on the same line, and then sometimes you might get some benefit with the major surgery, but when you are doing some minor procedures, we have to have these very specific, non-descriptive, easy to understand and easy to implement, and we have to where we have to have these SOPs. Not necessarily, some of the time it becomes too theory, too much theoretical. Some of the procedures are so simple where you really don't require SOP. You have to train your staff, just to do that work, and then, you can go ahead. This operational efficiency is very, very important, and I'll give you an example. As medical care is largely a commodity today, now we have to forget our days of those noble profession and telling doctor as a god or whatever. But today, not only because of this Consumer Protection Act said so, but the patients and population perception has changed over the years. So quality of care will only marginally distinguish a particular hospital, at least within a class of competent hospitals. I tell you, those were the days, one can say one particular surgeon and people used to, go into the plots for that surgeon. But today, that is not so. If today we take one example of CABG and done by the best of the surgeon in one of the hospitals, and not so best, I am saying, anyone can who does CABG competently, he is competent enough to do that kind of surgery. So there is a certain marginal difference, but there is no a major difference, of the outcome. So the CABG done in, say, 5 major hospitals in Pune, where it is done competently, so there is hardly any marginal difference between the two surgical patient outcome. So what is going to make a difference is the benefits like short waiting times, fast turnarounds. That is going to distinguish one hospital from another, and that is going to give you the better outcome. It's not that you employ the best of the doctors. Today, that was the days, gone to run the hospitals on the best of the doctors. Where now, today you have lots of best people. So you can get many people for many hospitals. So what is most important is what outcome you get out of these best peoples. Now when we talk about the patient care, it's again well written in the whole textbook, and it has been very well written by there's one book called, the management experiences of Mayo Clinic. I have gone through that book, and they have explained the patient first policy, and which is all universal for all hospitals, for all doctors. It is patient centered culture, high quality compassionate medical care, respect for the patient, family, and the respect for their family doctor. It should be comprehensive evaluation with timely, efficient assessment and treatment. But when I was going through this, again when we want to implement what is patient care, the talking is different, talking great is different, but when we want to implement, I have come through a very interesting phenomenon called checklist. And of course, in every hospital, I am not saying anything new. What I am saying, how it has to be implemented, how it has to be executed. All of you know the checklist literally is a written guide that walks through the key steps in a complex procedure, and which is very important when you want to get through a complex procedures of the surgery or the medicine, the checklist, because it will, eliminate those human errors. Or maybe suddenly you get something and sometimes you might forget, which is a very important point. And these checklists are best known used by those airplane pilots. Of course, as we doctors say, if you do some mistakes, only one patient suffers. But here in airplane industry, if the pilot does one mistake, there are many people, more than say 400, 500 people and their life is at stake. So these checklists are very, very well written, and they have been well guided and implemented in these pilot programs for long many years, and these are very important for us. And there was very important book written by the Checklist Manifesto by one Atul Gawande, who is a surgeon from Boston, and I feel people should, or our industry should read that Checklist Manifesto. Again, it should be very simple, done in a short time, should not be compulsory, should be done judiciously, and even there are examples of failed checklists, so people find it very difficult to employ it. Now I just want to put one line, because in the beginning the organizer told me to speak on emerging healthcare models in today's world, and I was going through, it may not be irrelevant to this. I come across and I hear, and a lot of you also hear, we talking about the doctor-patient ratio. And whenever we talk about doctor-patient ratio, and we use the word, it's very pathetic in India, but have anyone thought about, we have 1.2 billion population, and there are 6.5 lakh of allopathic doctors in this country, and the WHO everywhere in big letter world say that it comes only 0.64 thousand population, when the ideal standard global recommendation is 1 per thousand population, and the US has 1.3 something like that per thousand. But have you heard about, we have 7.5 lakh Ayush doctors in this country even today who has been legally permitted to practice allopathy. This is not a subject of my talk, but I am using the word they are legally permitted. So, for today and for whenever we are considering healthcare delivery and healthcare management, we have to consider them as a doctor. And when you consider those taken into consideration, our total number goes to almost 14 lakhs, and which is well beyond WHO recommendation of this doctor per population ratio. Think about it, make it, use of it. And now I'll not go next, Secondly, I just want to tell one line about, the duplicacy of the work. And this is what is happening again in our industry. Maybe it is a primary, secondary, tertiary care levels, but the duplication of work should not happen. And if, just an example, I have seen some tertiary hospitals abroad, where there is a transplant team and there is a big complicated surgery done. And you don't see, some cysts and lipomas are done. But this is not so in India. Maybe, there are different compulsions. But, if you think globally, if you think, positively, we have a big modular O2, we have such a high place infrastructure in a tertiary care hospital which require a big infrastructure. My friends will tell you how much it costs. And the same what if you do some cyst and some hernias and some lipomas, what kind of money you are using. So if we stick to tertiary care hospital, given the tertiary care, secondary care hospital given only secondary care and primary care, certainly I'm not talking on an individual level. Individual level, maybe we will have some losses, or the models will be different, but at a national level, certainly we'll do great if we try to implement such things. And thank you so much for giving this time to share my views. Thank you.
Good morning, everybody. First of all, I would like to apologize for coming late because due to the connectivity problem from Ahmedabad to Pune, and again there is a heavy rain in the Bombay, so flight was again delayed. That's fine. That's our Honorable Prime Minister is planning now. So I think I am the odd man here because I have seen the persons from the healthcare industries. I am from the Gujarat Pollution Control Board. So I have been given the topic to speak on the innovative infrastructure, particularly related to the environmental aspect in the pollution field in Gujarat. But again, one of the infrastructure is a biomedical waste rule also, and the handling of the biomedical waste generated from the healthcare units. I was seeing the two past previous speakers' presentations. It was a very good presentations, talked about the facilities and all these things in that. But unfortunately, I have not seen any SOPs or any slide for the handling of the biomedical waste particularly. So I think a very good hospital, at the end of the day, whatever the biomedical waste generated is not properly handled, then definitely the number of patients or the whatever the infection spreading outside and in the community will be large. If we, I don't know the scenario in the Maharashtra, but if I talk about the in Gujarat aspects, we are having 16 biomedical waste handling common facilities are there, and at every 100 kilometers there are the biomedical waste facilities. They are collecting the waste as per the rules. Within the 48 hours, whatever biomedical waste generated has to be disposed of to the incinerator site. Either it's incineration or it's autoclaving or it's whatever the categories are there. There are 6 to 7 categories are there. And as per the biomedical waste rules, 1998, every healthcare unit has to obtain the authorizations from the state pollution control boards. And suppose bedded hospitals are not there, and if it is either laboratories or OPDs are there, then if the number is increasing more than thousands, then they are required to obtain the authorization from the board. But every unit has to have a membership of the common biomedical waste facilities. I don't know the status about the biomedical waste facilities in Pune, but in Gujarat, we are having 16 biomedical waste facilities, and 1 lakh bed hospitals, bedded beds are covered under these biomedical waste facilities. We have done inventories in 5 years back. Still we feel that doctors and some healthcare units are still not covered under this biomedical waste. So we are going to organize one more inventories in that. But in short, my message to all is, in the forum like this, the biomedical waste management facilities and the hospitals, what are they doing with the facility? I am sure that it is reaching to the biomedical waste facilities only, common waste only. So other aspect, I think industrial, I have got my lecture on the industrial aspect, but I think it is not, it is not interesting for here, whatever the audience is there. Thank you very much for calling me.
We are approaching to the end of the session. This marathon session should have been for 2 days. The subject is so vast, it cannot be taken in one session with 7 or 8 speakers like this. But however, everybody tried to do that. I would request my co-chair, Dr. Manisha Ovre, to conclude as well as put the thoughts across.
Very good afternoon to all the dignitaries present here and to all my dear colleagues. It has been my great pleasure to be over here to chair this great session which has been with a huge panel over here. Everybody has been speaking about infrastructure. I am a combination of a clinician and an administrator. I am basically an intensivist, practicing for last 30 years. Right now as a CEO, so I understand the problem from both the ends. There cannot be a best clinical outcome without an excellent infrastructure, and every dignitary over here has spoken. What I am going to conclude, only the take-home message is a great planning is required before we raise an infrastructure, where we need to coordinate with all the end users to make the best possible infrastructure. And as Meeta madam had told us, that it is the infrastructure is not only the building, but it should be manned by a right credentialing manpower structure, considering right from the doctor up to the housekeeping team. And this manpower will run this infrastructure where all the procedures should be set in with the standardized protocols and guidelines. And this great job of standardizing the protocols and guidelines has been done already by our NABH board, and I take this opportunity to thank and congratulate our NABH board for spreading their word across our India, and more number of the hospitals are participating to make their hospitals accredited so that to deliver the best possible patient quality care. We all present here are doing our best possible to deliver the quality care with whatever the possible challenges I'm sure everybody must be facing. Here, Rajiv Lochhan madam is not here, and I'm sure e-health team will give the message to them. I would appeal to our Department of Health to come forward and to take best possible support of this NABH board. So to first make all our government sectors, corporation, hospitals to come nearby to a standard to deliver this quality care. This infrastructure being topic, I'll restrict to it. This infrastructure has helped us, whatever our Mr. Varun has told, everybody has told over here. All different expertise need each other's help. Let us be all come together, make the best possible use of each other's talents, and we can definitely reduce the cost, operational cost, make the quality service care best operational to give the best clinical outcome about it, and in nutshell, we can give a affordable community, affordable patient care service to whole of the community. This should be our aim, and this is what I wanted to appeal to Rajiv Lochhan madam. And I thank our e-health team to give us a common platform where the Department of Health has come together along with all the possible corporate sectors who have shared their thoughts over here, and we can definitely make a use of this forum to our best practices possible to reach to our community. Again, all the best to e-health team to keep doing the good job. Thank you.
Only 2 questions. So everybody will ask. Otherwise, we will continue the session. I think we'll conclude the session. I thank all the panelists. On their behalf, I thank you all for patient listening. Thank you very much.
Sir, momento.
You have some question?
No, sir. Momento giving. Thank you to all the panelists for this interesting session. Now, I will request session co-chair Dr. Manisha to please present a memento to our session chair Dr. Ravindra V. Karanjkar. A big round of applause for our speakers. Now I request session chairs to present mementos to our other panelists. Mr. Tarun Katiyar, Principal Consultant, Hospex Healthcare Business Consultancy Private Limited. Dr. A. Velumani, Chairman, Thyrocare Technologies Limited. Dr. Narendra Rungta, Chairman, Scientific Committee, Critical Care, Jeevan Rekha Critical Care and Trauma Hospital, Jaipur. Dr. N.J. Rathore, MD, General Medicine, Senior Consultant, National Health Mission, Committee of Maharashtra. Dr. Hanumant K. Saleh, Director, Noble Hospital, Pune. Dr. Srihari Duri Patil, Director, Shri Hospital and Diagnostic Center, Private Limited, Pune. Dr. G.S. Deviday, Senior Environment Engineer, Gujarat Pollution Control Board. Oh, sorry. I beg your pardon, sir. It's Mr. G.S. Deviday. Now I request Dr. Ravindra V. Karanjkar to present a memento to our session co-chair, Dr. Manisha Bobade, CEO, Jahangir Hospital, Pune. I request 2 speakers for a group photo on stage, please. Again, thank the chair, the session chair, the co-chair and all the panelists for this interesting session. Without any break, I would request for starting with the next session, which is on technology in healthcare, new initiatives and success stories. So for this session, I would like to invite the session chair, Budeb Chakravarti, Mr. Budeb Chakravarti, Associate Vice President and Region Head, National Institute for Smart Government, Hyderabad. Sir, please join us on the stage. A big round of applause for our speaker. Then I'll invite Ma'am Archana Samudra, Vice President, Palash Healthcare Systems Private Limited. Ma'am, please join us. सबका आए ना, सब आए ना? हाँ, ठीक है. Then I invite Dr. Shailesh Pandam Baker, Managing Director, Galaxy Care Hospital, Pune. Sir, please join us. A big round of applause for all our speakers who have to spare some time for us. Dr. Praveen D. Podar, Head Department of Molecular Medicine and Biology, Jaslok Hospital Research Center, Mumbai. Sir, please join us. Dr. Sandeep Solanke, Medical Director, JJ Mahanagar Blood Bank, Mumbai. So please join us. And as our last speaker, I invite Dr. Samita Jadhav, Deputy Director, Academic, Symbiosis Institute of Health Sciences, to join us on the stage. With this, I hand over the session to our session chair, Buddha Chakravarti ji. So,